The extensor tendon system is, frankly, completely unforgiving.
Oh, totally unforgiving. Zero margin for error.
Right. Because of its superficial location, right under the skin on the dorsum of the hand, it has a literal zero tolerance policy for tension changes. I mean, even a minor injury can lead to massive functional deficits.
Yeah, and that's exactly why we're doing this deep dive today.
Exactly. Welcome in, everyone. For this run-through, we are synthesizing clinical guidelines, anatomical breakdowns, and real-world surgical case studies to map out exactly how this anatomy tries to trap you.
It really does try to trap you.
It does. Our mission here is straightforward. We are breaking down the ER exam gotchas, the biomechanical rules of the operating room, and the pathomechanics of chronic deformities, so you don't get caught off guard.
That is the absolute reality of working on the dorsum of the hand. You are dealing with a system that demands uncompromising precision.
Fractions of a millimeter, right.
Literally fractions of a millimeter. That dictates whether a patient regains full gliding function or is left with a permanent rigid deformity. I mean, for anyone operating in the hand, whether you're a resident taking weekend call or an attending fielding complex reconstructions, understanding the inherent traps this anatomy sets for you is totally non-negotiable.
Definitely. So before we even think about making an incision or throwing a stitch, we need to talk about how this anatomy actively lies to you during a clinical exam.
Well, the exam lies all the time. The body is exceptionally good at masking extensor deficits.
Right, and to understand why, you have to keep track of the 12 extensor muscles in the forearm.
12 muscles, yeah. And the critical baseline here is that they were all innervated by the radial nerve directly, or, it's a terminal motor branch, the posterior interosseous nerve, the pine.
The classic exceptions you have to remember there are the brachioradialis, the extensor carpi radialis longus, and the extensor carpi radialis brevis, right?
Yeah, those come directly off the radial nerve proper, though the ECRB can sometimes be a transition zone and come off the PN, but essentially everything else is strictly PN territory.
And the key anatomical landmark for the distal end of that innervation is the extensor indicis proprius.
The EIP.
Exactly. The EIP is the most distally innervated muscle in that entire group, which makes it a crucial bellwether for nerve recovery. But let's look at where all this muscle mass funnels. As you move toward the wrist, these tendons run under the extensor retinaculum and get compartmentalized into 6 distinct dorsal compartments.
It's a massively high traffic area. 5 of those 6 compartments are fibro-osseous, meaning they have a bony floor and a fibrous roof.
But the 5th is the outlier.
Right. The 5th compartment, which houses the extensor digiti minimi, is the only purely fibrous compartment. It's situated right over the distal radial nalar joint. And clinically, you always have to keep your eye on the 3rd compartment.
Because of Lister's tubercle.
Exactly. That is where the extensor pollicis longus, the EPL, takes a sharp-angled turn around Lister's tubercle. That mechanical fulcrum becomes highly relevant when we look at distal radius fractures and attritional ruptures later on.
Let's ground this in real life for a second. I want to talk about the classic late-night ER consult.
Oh, I know exactly where you're going with this.
Right. A patient comes in with a messy dorsal hand laceration over zone 6, right over the metacarpals. The ER doc washes it out, asks the patient to extend their fingers, and magically the patient extends them perfectly.
It looks flawless.
Completely flawless. So the doc assumes the tendons are pristine, calls you to close the skin, and wants to send them home. But you get in there, you explore the wound, and the extensor digitorum communis to the ring finger is completely transected. The exam was perfect, but the tendon is literally in 2 pieces.
It is the ultimate clinical pitfall, and it catches people constantly. You're looking at the juncturae tendonae at work there.
The toe truck.
Exactly, the toe trucks. These are the oblique, interconnecting fibrous bands over the dorsum of the hand, located just proximal to the MCP joints. They connect the ring fingers EDC to the middle and small fingers, and for the middle to the index.
They act as a shared tension network.
Right. So the biomechanics here mean that even if the EDC tendon to the ring finger is completely blown out proximal to the juncturae, the middle or small finger EDC can literally pull the distal stump of the ring finger's tendon up into extension.
The adjacent intact tendons act like a tow truck for the cut tendon.
Precisely. The digit extends fully at the MCP joint. The patient masks the deficit, and the injury is completely missed if you just rely on active motion. This is exactly why surgical exploration under direct visualization is absolutely mandatory for these dorsal lacerations.
You just cannot trust the extension exam in zone 6.
Never.
Let's talk about another exam that routinely lies to you, testing the EPO. The EPL is the primary extensor of the interphalangeal joint of the thumb. But if you have a swollen, traumatized hand in the ER and you simply ask the patient to extend their thumb, the intrinsic muscles can completely mimic an intact EPL.
Yes, and that intrinsic substitution is incredibly powerful. The extensor pollicis brevis, the abductor pollicis brevis, and the flexor pollicis brevis all have expansions that insert onto the dorsal extensor apparatus of the thumb.
So if the EPL is cut,
If the EPL is cut, those intrinsics can still pull that apparatus and generate key joint extension. It looks like the EPL is working, but it is entirely a parlor trick by the thenar cone.
I've seen residents get fooled by that exact substitution so many times. So what is the foolproof maneuver to actually isolate the EPL in a busy clinic?
Here's the key point. Have the patient place their palm completely flat on the exam table.
Flat on the table.
Tell them to keep their palm glued to the surface. Then ask them to lift their thumb straight up off the table toward the ceiling. By forcing the hand flat, you mechanically neutralize the abductor and the short flexors.
They just can't fire in that vector.
Right. They cannot contribute to dorsal elevation.
Right.
If the patient can lift that thumb off the table, the EPL is definitively working. If it drags, the tendon is out.
Simple, mechanical, and bulletproof. Now, what about testing for a closed central slip rupture at the proximal interphalangeal joint? This is Elson's test. I wanted to dig into the actual biomechanics of what you're feeling here because it's brilliant.
Elson's test is a masterclass in isolating pathology. The central slip is the primary extensor of the PIP joint. If it ruptures from a jammed finger or a dislocation, you usually won't see the classic boutonniere deformity right away because the swelling splints the finger.
Right.
To test it, you isolate the PIP joint. You bend the patient's PIP joint to 90 degrees over the edge of a table or over your own finger. Then you ask the patient to actively extend the PIP joint against your manual resistance.
Let me push back on what you're actually looking for there, because if the central slip is blown, you obviously feel a lack of extension power at the PIP. But that lack of power isn't the true diagnostic part, right? It's what happens at the distal joint.
Exactly. The lack of power just tells you something is weak. The diagnostic hallmark is what the distal interphalangeal joint does. Normally, if the central slip is intact, when you resist PIP extension, the DIP joint stays relatively loose and floppy.
Because the force is anchored at the PIP.
Right. But if the central slip is ruptured, all that proximal extensor force has nowhere to go at the PIP, so it gets shunted directly into the intact lateral bands, which run past the PIP to insert on the distal phalanx.
So when they try to push against you, you feel no power at the PIP, but you simultaneously see and feel the DIP joint snap into rigid, powerful extension.
It's unmistakable.
The force just bypasses the broken central slip entirely and locks out the tip of the finger.
That's the tell. It is a pure mechanical bypass. So, having covered how the anatomy actively tries to deceive us in the exam room, we need to look at how the biology dictates our surgical approach.
And the reality is your surgical strategy completely flips depending on where you are in the hand.
Completely.
Down at the distal tip, we're handicapped by tissue that is practically microscopic, whereas proximally, we finally get robust tendon mass. Let's start distal. Zone 1, right over the DIP joint.
Zone 1 is a completely different beast. You are dealing with terminal tendon injuries, your classic mallet fingers. The tendon here is paper thin. You literally cannot put a core suture into it without destroying it.
We look at Doyle's classification here to guide us. Type 1 is your standard closed injury, no laceration, just a subcutaneous rupture of the terminal tendon from a sudden forced flexion.
The standard protocol here is non-operative. We are talking 6 to 8 weeks of continuous, uninterrupted splinting of the DIP joint in slight hyperextension, followed by another 4 to 6 weeks of night splinting.
But let me push back on this textbook ideal. In a perfect world, sure, 8 weeks of splinting works. But in real life, patient compliance is abysmal.
Oh, it's terrible.
You are asking a mechanic or a nurse to keep a splint on 24/7 for 2 months. If they take it off in week 5 to wash their hands and the finger drops into flexion, does the clock really restart from day 1?
Biologically, yes. The clock restarts. That healing tissue is basically a fragile bridge of scar collagen. If they let the DIP flex, that microscopic scar stretches out or tears, and you're back to square one.
Which is devastating for the patient to hear.
It is. That is why you have to counsel them aggressively from day 1. You also need to manage their expectations. You have to tell them upfront that even with perfect compliance, a 10 to 15 degree extensor lag is a normal expected outcome.
It's essentially a permanent, mild ptosis for the fingertip. It droops just a little bit, and that is still considered a functional win.
Ex-
But what about the patients who absolutely cannot or will not tolerate an external splint for 2 straight months? Like, say, a surgical resident or an attending who has to scrub into the OR every day. You can't scrub with a bulky plastic stack splint on your finger.
No, you definitely can't. For those specific high-demand cases, we utilize what's commonly called the surgeon's mallet. We take them to the OR, prep them out, and drive a smooth K-wire longitudinally across the DIP joint, burying the pin beneath the skin.
You're internally splinting the joint in rigid extension.
Exactly. It achieves the exact same mechanical lockout as a plastic splint, but it allows the surgeon to scrub their hands and keep operating. You pull a pin in the clinic at 6 weeks.
That is a fantastic real-world workaround.
Yeah.
Now, within Zone 1 injuries, we also have to talk about the Type 4A mallet.
That's the Seymour's fractures.
Right, physial fractures of the distal phalanx in pediatric patients. And there is a massive limb-threatening pitfall here if you aren't paying attention.
It's the hidden open fracture. A kid slams their finger in a car door. They show up in the ER with a mallet deformity, and maybe the proximal edge of the nail looks a little lifted or disrupted.
The temptation is to just throw a splint on it and send them to the pediatric clinic.
But you have to look closely under that epinicial fold because the proximal edge of the nail plate actually avulses out of the germinal matrix, and right underneath that lifted nail is an open fracture of the distal phalanx physis.
Wow.
If a resident just slaps a splint on that without exploring it, you are trapping a dirty, contaminated wound right over bone. You are literally buying that kid a ticket to osteomyelitis and a potential amputation.
In real life, you have to formally wash it out, debride the matrix, reduce the fracture, fix it with an axial K-wire across the DIP, and carefully repair the nail bed. It is an operative emergency, not a clinic referral.
Absolutely.
Let's talk about why these distal injuries are so unforgiving mechanically. This brings us to the excursion trap. The extensor system in the distal finger operates like a perfectly calibrated high-tension wire.
Very high tension.
At the DIP joint, the tendon only has 0.6 millimeters of excursion for every 10 degrees of joint movement. Let me repeat that. 0.6 millimeters.
That is virtually nothing. That is less than the thickness of the actual suture material you're using.
Right. So if you have an open laceration in zone 2 over the middle phalanx and you try to place a robust, bulky core suture to bring the ends together, you're going to inadvertently shorten the tendon and add inflammatory mass.
And because the excursion tolerance is so microscopic, shortening that tendon by even 2 millimeters means you instantly lose a massive arc of motion. You just killed the mechanics of the finger.
That is exactly why, for zone 2 lacerations, if it involves more than 50% of the tendon width, you abandon core sutures completely. You use a fine, running epitendinous suture like a 5-0 or 6-0 non-absorbable.
You simply bring the edges together edge to edge without bunching them up.
Right, and then you rely on biology and splinting. You splint the DIP in extension for 6 weeks, but you actively mobilize the PIP joint to prevent proximal adhesions.
Moving proximal from there, we hit zone 3, right over the PIP joint. This is central slip territory. And the anatomy here dictates that open zone 3 injuries frequently breach the PIP joint capsule.
Absolutely. So your very first step in a zone 3 laceration is a formal, aggressive washout of the PIP joint to prevent septic arthritis. Once the joint is clean, you assess the central slip.
If it's lacerated more than 50%, you repair it directly.
But if it's been avulsed completely off its bony insertion at the base of the middle phalanx, you have to use bone tunnels or a microsuture anchor to reattach it.
And the post-op protocol here relies on isolating the joints. You pin or splint the PIP joint in rigid, absolute extension for 6 weeks. But you must let the patient actively flex the DIP joint during that time.
That active DIP flexion is the secret to a good outcome. When the patient flexes the DIP, they are physically pulling the lateral bands distally.
Right, that constant gliding prevents those lateral bands from scarring down to the healing central slip in the joint capsule. If you lock the whole finger out, they will end up with a stiff, useless digit.
So in those distal zones, we are handcuffed by paper-thin tissue and zero excursion tolerance. But as you cross the MCP joint and move into the proximal zones, zones 4 through 8, the biomechanics and the surgical reality totally shift.
You finally have enough tendon mass to place a real multi-strand core repair. But the trade-off is that the mechanisms of injury get significantly dirtier and more complex.
Zone 5 is a perfect example. This is right over the MCP joint, the knuckles. And the absolute classic mechanism here is the human bite, the punch to the mouth injury.
Oh, I'll tell you right now, patients lie about this 100% of the time. They walk into the ER with a swollen knuckle and a tiny, innocent-looking 5 mm laceration. They will look you in the eye and say they cut it on a fence or a piece of glass or a car door.
But you look at the wound edges, and it is a perfectly jagged tooth mark.
Never trust the history on a knuckle laceration. You have to assume it is a fight bite until proven otherwise. And the pathomechanics of this injury are fascinating and are really dangerous.
Because of the position of the hand during the impact.
Exactly. When the patient throws the punch, their NCP joint is maximally flexed. The extensor tendon is pulled tight over the knuckle. The opponent's tooth penetrates the skin, slices through the extensor tendon, and breaches the dorsal capsule of the joint.
Then the fight ends. The patient goes to the ER and opens their hand to show you the cut. When they extend their finger, the extensor tendon glides proximally by about 10 to 15 millimeters.
It takes all that incredibly aggressive oral fluorocanilla, strep viridans, staph ham, and drags it deep into the joint space. The intact distal portion of the tendon then slides over the capsular defect and completely seals the joint shut.
It becomes a pressurized incubator for septic arthritis.
The cartilage will be destroyed in a matter of days. The clinical rule here is absolute. You explore the wound aggressively, you look for that dorsal capsule breach, you wash the joint out with liters of fluid, and then you defer the tendon repair.
You leave the wound open to drain. Do not ever close a human bite over a fresh tendon repair. Wash it out, start broad-spectrum IV antibiotics, and walk away.
Let's stick with Zone 5 and look at a closed injury, sagittal band ruptures. The sagittal bands are essentially a stabilizing sling. They wrap around the base of the proximal phalanx and hold the extensor tendon perfectly centralized over the MCP joint during motion.
If that sagittal band tears, the tendon loses its sling and subluxes away from the site of the injury. We see these close snaps frequently in boxers or laborers.
It usually happens from blunt trauma or forced resisted extension, and classically it involves the radial side of the middle or ring fingers. The radial sagittal band tears, and the extensor tendon violently subluxes ulnarly, dropping down into the valley between the metacarpal heads.
The presentation is unmistakable. The patient will literally feel and hear a snapping sensation when they flex their finger. And when they make a full fist, the tendon drops into the gutter.
Because it's sitting below the axis of rotation, they cannot actively initiate extension. They have to use their other hand to passively lift the finger up, at which point the tendon snaps back to the top of the knuckle and they can hold it there.
You always want to check the opposite hand because some patients just have baseline hyperlaxity and naturally subluxing tendons without any pain. But if it is a true acute closed injury and you catch it within 3 weeks, you can actually treat it without surgery.
Right, you use a specialized flexion block splint. It limits MCP flexion to about 20 degrees, preventing the tendon from dropping into the gutter, but allows the sagittal band to heal in its proper centralized position. They wear it continuously for up to 8 weeks.
If they fail non-operative management or they show up 3 months late, you are going to the OR to surgically reconstruct that band using a slip of the extensor tendon itself.
Moving further proximal, we hit Zone 7, the wrist. This is the real estate directly under the extensor retinaculum.
When you repair tendons in Zone 7, you obviously have to open the retinacular roof to access them. But there's a massive clinical pearl here regarding the extensor pollicis longus.
Oh, this is crucial.
If you are repairing lacerations to the extensor carpi radialis longus and brevis, which sit in the second compartment, you're going to be throwing thick core sutures and leaving bulky knots right under that retinaculum.
And the EPL, sitting in the third compartment, runs immediately adjacent to those repairs, angling right over Lister's tubercle.
Yes. So if you just close the retinaculum normally, that EPL tendon is going to repeatedly glide back and forth directly across your coarse, non-absorbable suture knots every time the patient moves their thumb. The friction is relentless.
Within a few months, it will cause an attritional rupture of the EPL. So the rule is, after you repair the ECRL and ECRB, you must transpose the EPL tendon subcutaneously.
You route it completely outside of its normal fibro-osseous tunnel, leaving it in the subcutaneous fat where it can glide smoothly without friction.
Transpose the EPL. It saves you from a totally preventable complication. Finally, Zone 8 is the muscle belly itself up in the proximal forearm.
Muscle is highly friable. It's basically meat. It holds suture very poorly compared to the dense collagen of a tendon.
If you have a laceration at the musculotendinous junction, You place the best figure-of-8 repair you can, augment it by repairing the overlying muscle belly fascia to take tension off, and you rely heavily on static post-op splinting because the repair is structurally weak.
But the critical surgical step in Zone 8 isn't actually the muscle, it's the nerve.
Absolutely. You must meticulously explore the posterior interosseous nerve. The pine arborizes right through this area. If you find lacerations in the intra or extramuscular branches of the pine, you must repair them using microsurgical techniques.
Sewing the muscle back together is useless if you don't save the nerve, because repairing the peon is the only way you preserve the motor function of the distal muscles like the EPL, EIP, APL, and EPB.
So we've covered the acute trauma. Let's look at what happens when acute management fails, or when a chronic inflammatory disease like rheumatoid arthritis systematically destroys the delicate balance of this entire system over years.
You end up with the classic chronic deformities. The biomechanics of these are fascinating. Let's start with the swan-necked deformity.
Swan neck is a very specific postural collapse. It's characterized by severe hyperextension at the PIP joint and reciprocal forced flexion at the DIP joint. The functional deficit is huge because the patient physically cannot make a full fist. The PIP joint locks out and refuses to flex.
What makes swan neck so challenging clinically is that the finger looks exactly the same, but the pathology driving that collapse can originate from 4 entirely different locations in the hand and wrist. It is a total system failure.
That is exactly right. Let's break down the 4 origins. First, it can start at the PIP joint itself. Chronic synovitis aggressively stretches out the volar plate and the transverse retinacular ligament.
Once those stabilizers are loose, the lateral bands are free to sublux dorsally, moving above the axis of rotation.
They act like a bowstring, pulling the PIP into hyperextension, which subsequently pulls the DIP into flexion.
The second origin is the MCP joint. Synovitis here weakens the insertion of the long extensor tendon. Because the extensor loses its proximal anchor, all of that extension power is shunted distally onto the middle phalanx, snapping the PIP joint back into hyperextension.
Third, it can actually start all the way distal at the DIP joint. If the terminal tendon ruptures, basically an untreated chronic mallet finger, the lateral bands retract proximally.
Because they are no longer tethered at the tip, all the extensor force from the intrinsic muscles is now concentrated entirely on the central slip insertion at the middle phalanx, again, hyperextending the PIP joint.
And the fourth origin is the wrist, which I think really highlights how deeply interconnected the entire forearm and hand are. Severe rheumatoid synovitis at the wrist joint leads to carpal collapse. The carpal bones settle, and the wrist shortens.
Carpal collapse causes a relative lengthening of both the extrinsic flexor and extrinsic extensor tendons. They lose their resting tension.
Because they are suddenly too long and slack, the short intrinsic muscles in the hand completely overpower them. This intrinsic tightness violently pulls the MCP joint into flexion and drives the PIP joint into fixed hyperextension, eventually leading to a rigid swan neck.
4 completely different starting points, all leading to one devastating final deformity. Now, contrast the swan neck with the boutonniere deformity.
Boutonniere presents with the exact opposite posture. You see rigid flexion of the PIP joint and hyperextension of the DIP joint. And unlike swan neck, which is a system-wide failure, boutonniere pathology originates purely and strictly at the PIP joint.
It always starts with the failure of the central slip.
Yes. The central slip either ruptures from acute trauma or stretches out from chronic synovitis. Once the central slip goes, the triangular ligament over the dorsum of the middle phalanx inevitably stretches out as well.
Without that dorsal tether, the lateral bands begin to slide down, subluxing in a volar direction until they drop anterior to the axis of rotation of the PIP joint.
So the biomechanical vector completely flips. Instead of extending the PIP joint, the lateral bands are now acting as flexors, actively pulling the PIP down.
And all the force generated by the lumbricals and interossae bypasses the PIP completely, shunting distally to rigidly extend the DIP joint.
It creates a brutally fixed contracture. For early stages, where the joints are still passively supple, you treat it by splinting the PIP in absolute full extension for 2 to 3 months, while forcing the patient to actively flex the DIP joint to stretch those lateral bands back out.
You only consider complex surgical reconstruction if they fail months of aggressive splinting.
To wrap up the operative strategies, let's talk about tendon transfers. We discussed the EPL suffering an attritional rupture from suture knots, but the most famous scenario for an EPL rupture is following a distal radius fracture.
It is incredibly common. The EPL ruptures whether the radius fracture was treated non-operatively in a cast or fixed surgically with a volar plate or a dorsal plate.
The tendon gets irritated by the fracture hematoma, or it frays mechanically over the bone callus or prominent hardware until it finally snaps weeks later.
By the time you get in there to explore it, the tendon ends look like a frayed mop head. The tissue is completely degenerated. Direct repair is biologically impossible.
So you need a donor tendon to restore thumb extension. And the absolute gold standard transfer here is taking the extensor indicis proprius, the EIP, and rerouting it to the EPL.
The EIP is the perfect donor. First, it is synergistic, meaning the patient's brain already fires it to create extension, making post-op rehab much easier.
Second, it has an almost identical excursion and force profile to the native EPL.
Third, it is easily harvested through a small incision at the MCP joint with minimal donor site morbidity.
And the beautiful part is, because the index finger has its own dedicated slip of the common extensor, the EDC, the patient fully maintains independent index finger extension even after you harvest the EIP.
It is a truly elegant anatomical solution to a devastating complication. All right, let's run through a quick, rapid-fire recap of the highest yield clinical pearls. Number 1, always watch out for the juncturae tendonae masking complete zone 6 lacerations. Never trust a normal extension exam over the metacarpals.
Number 2, to properly isolate and test the EPL, force the patient to place their palm completely flat on the exam table to neutralize the intrinsics.
Number 3, beware the hidden open Seymour fracture hiding under the epinicule fold in pediatric mallet fingers. Wash it out, or you are buying an infection.
Number 4, always transpose the EPL subcutaneously after repairing tendons in the second dorsal compartment to prevent attritional rupture.
Treating the extensor system is ultimately a massive game of tension and millimeters. We talked about how the DIP joint only has 0.6 millimeters of excursion tolerance for every 10 degrees of motion. It really leaves you wondering about the future trajectory of hand surgery. Well, if biological tendon grafts and standard core sutures always carry the inherent risk of scarring, bulk, and restrictive adhesions, will the future rely entirely on synthetic biomaterials?
Oh, wow.
Right. Imagine materials engineered in the OR to match that exact 0.6 millimeter tension profile flawlessly, completely bypassing the biologic inflammatory response, and eventually rendering our elegant tendon transfers totally obsolete.
It is a profound question of engineering finally matching the demands of biology.
Yeah.
When we can manufacture excursion that precisely without scar, the way we reconstruct the traumatized hand will change entirely.
Definitely something to think about the next time you're trying to perfectly balance a core knot in Zone 4. Thanks for joining us on this deep dive. Keep those tension lines perfectly balanced, and we will see you next time.